Hello, I'm John Lauriello. On behalf of CME Outfitters, I'd like to thank you for joining us for episode 2 of this 3-part CMEO Snack series on overcoming barriers to the use of long-acting injectables in schizophrenia management, because every patient deserves recovery. Today's episode is titled Long-Acting Injectables in Schizophrenia, an evidence-based strategy to get your patients to remission and recovery, supported by an educational grant from Alchemies, and is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Again, I'm John Lauriello. I'm the Daniel Lieberman Professor and Chair of Psychiatry and Human Behavior and the Senior Vice President of Behavioral Health at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, Pennsylvania. I'm pleased to be joined today by Deanna Kelly, the Professor of Psychiatry and Director of the Treatment Research Program at Maryland Psychiatric Research Center at the University of Maryland School of Medicine in Baltimore, Maryland. Welcome, Deanna.
Thanks so much, John. It's my pleasure to be here today.
To frame today's episode, let's start by reviewing our learning objective, which is to formulate practice strategies for the use of LAIs in patients with schizophrenia, while considering treatment initiation, dose, and dosing schedules. Deanna, let's jump right into this. What is the problem that long-acting injectables are trying to solve?
Sure. So John, one of the big issues in our treatment of people with severe mental illness and schizophrenia is the issue of adherence. It's really a big deal, and this is a big issue we all struggle with. Even, you and I, we all have trouble taking our medications, but this is a major issue. We have over half of our patients who are non-adherent to treatment at some point. And this study that I'm thinking of right now is looking at patients who are discharged after their first treatment at hospitalization, and just thinking about in over 2,000 patients, we have data to show that 58% of patients use their antipsychotic during the first 30 days after discharge, only 58%. 46% of those continue their initial antipsychotic more than 30 days. So this is less than 50% of our patients. And what's more alarming is that data shows us that over half of our patients, after being admitted for the first time and discharged, do not even get their prescription filled within the 30 days post-discharge. So we're dealing with a population, for lots of reasons, that's really, really challenging to take our medication. So adherence becomes a major issue.
Yeah, I mean, we've seen this in our own practices, obviously. When we've given discharge prescriptions, we sometimes find them in the garbage after the patient has left the hospital. Or if we give them maybe a 14-day supply, getting them to the next prescription, to the pharmacy the next time, is a real challenge. So I think this is a real experience that we're having. Getting people to really connect to their medications and to use them is really a challenge, especially in people who have schizophrenia. What are some of the reasons for patients not taking their medications?
Yeah, and this is a good question. I mean, we're faced with a couple of issues. One is that there's this sort of the issue is they will not take them or they cannot. I mean, we have both kind of these issues. I mean, if they will not, we really need to kind of talk about helping them with perceived benefits and have different strategies. But if they cannot, we need to have processes in place or make selections that will help them be able to remember to take their medication. I mean, there are lots of reasons for non-adherence, and I mean, some things could be they have side effects, they don't understand, they the regimen could be very complex. I mean, we could have many pills per day, and those are challenges. But some of the major barriers, some of the major reasons for non-adherence include that the patient doesn't believe that they need to take a treatment. I mean, the insight issue is a real issue. Also, poor therapeutic alliance with the clinician. Having that mistrust in why they should be taking this medication. Forgetfulness. I mean, just forgetting to take their medication. I mean, we have patients that are cognitively, impaired. It's challenging in a day-to-day to function in normal ways in our society. And just forgetting to take the treatment is another one. So there's lots of reasons for non-adherence, and our slide here shows us that there are lots, there are lots of reasons. But like to hear if you have any other comments. But there's a lot of challenges.
Yeah, I think, I often say that insight or lack of insight should be a cardinal symptom of schizophrenia. It is not, but it is a day-to-day plague that we deal with because, our patients, they have every right to be skeptical of what we do. But when they don't even believe they have an illness, it's a really uphill battle sometimes to get them to take medication. One of the things that's not listed here is you really do need the family and friends and everybody sort of rowing in the same direction when it comes to medications. So sometimes we encounter families that are really hostile to taking medications and sort of support not taking them. So it's multifactorial, and the solution is relatively complicated as well, which includes, getting the patient to understand the implications of their illness, getting the family to buy in, and then making the medication delivery, first of all, the complexity as simple as possible and the delivery as simple as possible.
And John, we also thought that the second generation antipsychotics, as we watched them come out, that they might be helpful in the adherence issue, right? We kind of thought, and that's not solved our problem. That hasn't solved the issue. So
absolutely. This is a great point. I gave some of the first lectures on risperidone oral when it came out, and I literally said, "Oh, patients are going to start taking the medications because they won't have EPS and extrapyramidal symptoms and other side effects that the first generations have. So we're gonna do so much better." And lo and behold, we're still struggling with the same thing because yes, we have less EPS. We have other side effects, weight gain, and other things that are problematic with the second generation. But the fundamental thing that we're talking about, this connection between the need to take the medication and their success as a person in their functioning, it takes a while sometimes for people to connect to that. And that's our real challenge. And the biggest thing that is to worry about is that when you do get sick again, you lose more and more of the things you want. So you lose your job, you lose your housing, you lose your school. So it isn't like it's a theoretical problem. It's a real problem if you get sick again. It really does affect you. So, we're talking high stakes here. And so that's why it's so important to think about how do we get people to take their medications, go to treatment, go to psychotherapies that are offered, all of those kinds of things. Deanna, the APA has offered a statement on the use of long-acting injectables. I'll read it here. Patients receive treatment with a long-acting injectable antipsychotic medication if they prefer such treatment or if they have a history of poor or uncertain adherence. I mean, what do you think about how, that's a relatively recent, that's just a year ago that the APA came out with this. What do you think of this statement?
So I think we missed the boat here. I think in 2020 we have new guidelines that come out, and I think we could have done better with this recommendation. I think it could have been I think the next iteration we're not going to be able to ignore the evidence that's out there, and we'll talk about what that evidence is in the next few discussions that we have. I think, but I think that just going for patients if they have a history of poor or uncertain adherence is a little bit too vague here. I mean, a lot of our patients have problems with adherence, and I think that there's benefits outside of just having to document this history of non-adherence. And the issue of if they prefer, I mean, that's still a little bit vague. I think we could have done a lot better. Because if we haven't told them about them, if we haven't discussed the medications with them, and we have evidence to suggest that these discussions don't happen, then their preferences might not even include a long-acting injectable. So I think that the way this is framed just wasn't it wasn't in line with exactly the evidence. But the other guidelines recommend similar, the NICE guidelines, the New England Australian. But I would think, John, I'd like to hear what you think, is that with all the evidence coming, that the next iteration of guidelines will probably be a little bit stronger on the benefits of long acting, just not in those who are deemed history of poor adherence. Because we have a lot of new patients we're starting on treatment early in their phase of illness. And we often have the mentality that even long actings are reserved for chronically ill patients. And that's not the case. We need to change that mindset. And this is kind of reflected in this statement. I'd like to hear what you have to say.
No, I couldn't agree more. Listen, I have a great respect for the APA practice guidelines. I think they didn't spend a lot of time on LAIs, just like a page, and they spent 10 pages on clozapine, which I also greatly believe in. But the reality is there's a lot more people who will be getting LAIs than clozapine in this country. And I think they didn't really want to make a definitive statement. I think for those of us who use LAIs a lot and who've studied them like you have, we think this should be a beginning conversation. This should be in the beginning of any conversation. And that's not what the guidelines are really pushing. They're really saying, well, if the person doesn't take medications, well, why are you waiting for that? That's when people are losing the most in the beginning. So at least have that conversation. So I guess I would have preferred them saying, as you offer antipsychotics, which the APA absolutely, endorses for schizophrenia, include LAIs in the first conversations. I think that would have been better, frankly. I think it would have sent a different message. But, I think you're right. The next time the evidence continues to mount, there are more options. I think this should become more and more of a standard praxis. Because I think we are talking about how do the LAIs compare to oral antipsychotics. And so you were mentioning, Deanna, that there is evidence that taking long-acting injectables work, and they can compare favorably to orals. Can you talk a little bit about that?
Sure. So, let me just first, before we kind of go into that, maybe we just talk a few seconds just about the reasons why they're not used, or reasons why we should use them, and we'll kind of go into that evidence. But the issues with long acting, like why we might want to use them versus the negative of not, but it eliminates the guesswork of sort of knowing if they're non-adherent or if they're adherent or non-adherent. It does help us disentangle reasons for poor response. I mean, we know then that they have the medication on board. It eliminates that need to remember. It eliminates the loss of efficacy with just a few missed doses because we have a medication on board. We have predictable plasma levels. We could go on and on with a few other benefits. We eliminate the first pass effect, so we kind of can get a better ratio of the dose to response. But there's lots of reasons then why people still don't use them. And so many examples, we often overestimate their degree of adherence. We think our patients might be more adherent than they are. We don't have a lot of evidence to sort of, besides refill rates or maybe checking their bottles when they come in or just talking with them. But we often sort of might miss or underestimate. But then there's this bias against long-acting injectables. And this is not just, we think that it might be our patients who don't want to get needles or get injections, but in reality, it's often the providers that overestimate that issue. I mean, we've done work where we've published that patients don't really mind the blood draws. We think that we cause them pain and it's inconvenience and it's a problem, and really they rate it really low on things that bother them. And that's not one of them. So there's a whole list of issues or reasons on this slide why LAIs are not widely used. And then we have the issue of why aren't we using in early phase schizophrenia? And I mentioned earlier that we have this mentality that these are reserved for chronically ill patients. In reality, like you said, we should be having these conversations right from the get-go. And people, in our training, when I was trained, we only had two depots. We had, haloperidol and flufenazine, and they have their issues too. But, or the training that we had wasn't in a time where there was a lot of options. And so I think education or inadequate training or like feeling competent in using these, strategies are also problems, which is why education is important. But, those are just a couple of reasons why they're not widely used in early
Yeah,
phases.
I would say I think it's a predominantly a clinician problem and less of a patient problem. I think clinicians are just not, after all these years of preaching to the masses, not to the choir, but to the masses, we haven't made the dent we would like to with clinicians to understand that, this is not invading the patient's privacy or rights. This is really trying to deliver a system that we think can work better for a lot of people, because it's really, really difficult to take medications every single day. And it's certainly difficult when you have issues with ongoing symptoms or problems with really believing you have the illness. So I really do think that, one of the reasons we do these snacks is to connect to clinicians and providers and nurses and case managers and all those people to kind of get them on board to really think about this. We don't think everybody should be on LAIs, but we certainly should think everybody should have that considered in the conversation. And I think that's what you're really talking about. And we had a lot of experience giving a lot of injections in many of the pivotal trials. And you're right, the patients, by and large, are really pretty accepting of it if you do it, correctly, and you have, a good technique. There's usually no problem, and it's a lot easier than necessarily fighting with your mom about a pill every day, or a couple of pills every day, which can be often the alternative. Mm-hmm. So going back to the idea of why the what is the LAI's advantages, say, vis-a-vis the orals? What you were mentioning some data that now shows some advantages to LAIs. Can you talk a little bit about that?
Sure. So the idea of relapse. Let's talk a little bit about relapse. So when we're non-adherent to medications, our patients can have relapses. And so relapses are bad for lots of reasons. I mean, there's functional decline. You alluded to this earlier. There's this functional decline potentially with each relapse. There's evidence to suggest that possibly there is some loss in prefrontal gray matter. So biologically, there might be consequences of relapse. There's marked consequences to people's work and their psychosocial, like the interactions, etc. When you're having a relapse, you end up in the hospital. It's costly. It sets us back, and it sets the patient back in particular. So it's problematic. So that's just one of the many issues with non-adherence. And this is where long-acting injectables can come in. So really the idea of adherence is sort of the easiest thing. Like, can we improve adherence? And we can talk more about relapse and we will in a few slides, but adherence is still going to be is a problem no matter what. So even if we're giving a long-acting injectable, and you can see some of the data here, we're looking at 1 year and 2 year medication compliance rates. This is Christoph Carell's publication last year. There still are a few people, and less than 20% in these studies at 1 and 2 years that aren't getting their long-acting injectables. So not everyone's going to be 100% compliant, but that's less than 20% of our patients. So people won't necessarily, some people won't come back, but the majority of people do here are adherent. And we guarantee, constant treatment or constant medication while you're on the treatment. So they're getting more days of medication. But then there's the idea of adherence. We get it. It's an easy one. We get that, giving a long-acting. But what about the other things that benefits? And I think we have a lot more to talk about here. For example, Christoph's data shows us that relapse rates, and here you can see the big difference between the orals and the long-acting at 1 year and 2 years. Relapse rates are higher, significantly so, in those who have been on oral treatment. So we can guarantee adherence, but we can also then improve some of these bad outcomes like relapse.
Yeah, and I think relapse, which often is equated with rehospitalizations, is just one of the factors that we deal with when a person is living with schizophrenia. So if you're not taking your medications, you might not be back in the hospital, but you may be having ongoing symptoms. You may be interacting with family and friends very poorly. You may be staying in your room because you just are not motivated to do things. There's so many things that occur when a patient remains symptomatic. And LAIs are not a cure-all or a panacea. They are one tool in the toolbox, a major tool, I would say, in the toolbox. And they can reduce some of those ongoing morbidities that a person has. The other thing that I think you've mentioned that we just have to repeat over and over again, when a patient's on a long-acting injectable, when they don't show up for their next injection, they have put a flag in the ground saying that they're not taking their medication, and that's a big thing, because we can then rally around, call the family, call their case manager, call them, say, hey, what's going on? You didn't show up for your injection. It could be a financial reason. It could be lots of reasons. But we know right away. How many times when I've worked in the emergency room, patients come in and relapse, and trailing behind them is their mom or dad with a bag full of medication bottles that half of them still have medicines in them. So I do think it's important to really try to be as dynamic in real time, understanding a person's medication adherence. And long-acting injectables are better at that than, say, orals, where you could be off for months and no one would even know it.
Right.
You could fill the prescriptions and just throw them away and no one would even know it. So that really is the challenge. Mm-hmm. Talking about data, we just had a big recent meta-analysis of real-world studies that were published between 2010 and 2020, looking at some of these differences between orals and LAIs. And I think that's worth going through and just kind of reinforcing some of the things we've already talked about. So, Deanna, can you walk us through some of this data that came out of this Lynn study?
Sure. Yeah, this was, like you said, a big meta-analysis that came out this past year. And they looked at many studies. In the end, 25 sort of made it down in. And here you can see a list of studies that they felt were worthy to put into the idea of adherence. This outcome is looking at treatment adherence. And we've already kind of touched upon this. But I think what's interesting is you look at different systems of care here. We have Medicaid data, we have VA data, we have other administrative claim data. These are all large. Many of these are large studies that were included, and pretty much across the board. And this is where we have the really consistent data when we're looking at adherence, is that in the realm of favoring the LAI, so that you can see that the odds ratio sort of favors LAI in all of these studies across different systems. We understand that, like we said, there's no one that's going to be 100% adherence. We still have adherence issues in refilling, but we can better understand that when they're taking LAIs. But here again, it's favored across the systems in terms of understanding that if you take a long-acting injectable, that the adherence rates are better than they are with orals in this meta-analysis.
Yeah, I think one thing we didn't mention that is important is, if you're on an LAI, and we found this in multiple studies that we did, your medication regimen actually gets simplified. So often you're only on the injectable and nothing else. Often when you're on orals, you're chasing non-adherence by adding more medicines. And so a patient might be on 5 different medicines, none of them that they're taking fully. And we were struck by, when we put people on LAIs in some of the trials we did, we actually simplified their treatments pretty dramatically. Get sometimes just the injection, sometimes an injection plus an antidepressant or something like that. The long-acting injectable provides what I often call the stable platform. It gives you a place to start. If you know that the person is getting their antipsychotic and you know it day in and day out, then you can decide, okay, with that sort of at least dealt with, does the patient need a mood stabilizer? Does the patient need an antidepressant? What do they need? And if they don't need it, don't give it to them. But if they do need it, at least you know that you've built the base with the idea of the antipsychotic being guaranteed, at least for the time that they come for their injections. And so I think that's really important. It's not just the treatment adherence of the antipsychotic, it's really the simplification of the regimen and the treatment adherence of other things that they may need to take. So I do think there's a lot.
Yeah, that's a really great point, because polypharmacy, lots of other medications are without their own risks. I mean, we can potentially add other side effects and other problems. And, I'm not saying that with an LAI, I do see patients, and I work in the Medicaid system in Maryland too, look at data. I do see people that are on all kinds of different regimens, and some people are still taking other antipsychotics. But generally, we have the opportunity here, like you said, to be able to reduce that medication complexity and hopefully be able to get down to the prime antipsychotic, and then you can go from there. That what you said is, I think, really important points.
Why don't you talk a little bit more about some of the data that they showed in the meta-analysis?
Sure. So they also looked at some of the other things that are easy to measure in administrative data are hospitalizations and ER visits, et cetera. But the number of hospitalizations is another sort of outcome that they picked up, and you can see the same sort of administrative claims data that's listed here. And they looked at time to rehospitalization. LAIs had 25% fewer all-cause hospitalizations overall compared to orals, and we'll talk a little bit about that when we talk about costs in a few minutes. But hospitalization stays are very expensive. I think that on average in our country, we're somewhere between $10,000 and $13,000 a night. I mean, maybe a little off, but it's very, very expensive to stay in the hospital. So it's not only cost to our system with hospitalizations, but also it's very disruptive to our patients to have to bring them in to the hospital and the relapse. But the hospitalization is one way to measure sort of when we talk relapse or when things aren't going well with our patients. I mean, this could pick up things like suicidality or relapse or not doing well, but it's one way to be able to get an idea in administrative claims data, and it favors across the board pretty much in most of the data that if you're treated with a long-acting injectable, that you have a lower risk of hospitalization with the continued delivery of medication compared to orals.
And likewise with ER visits, there's also some data there as well, right?
Yeah, of course. And ER visits another way to in administrative claims data to be able to pick up, an outcomes we can look at. And ER visits, as you know, as we all know, they're really disruptive. I mean, they're stressful. Going into the ER is challenging. It's noisy. You're often held in a bed, in the room for a long time. Our ERs are not actually across the board that well equipped to be, working with psychotic patients coming in. So it's just becomes a real challenge when you go to the emergency room. But nonetheless, ER visits, we would like to cut down on them. We'd rather be able to keep our patients out of the ERs and out of the hospitals if we can. And again, this from this meta-analysis, this Lynn meta-analysis that came out in the studies that they looked at, as you can see, across the board, pretty much we have it favoring the long-acting injectable for a decrease in all-cause emergency room visits in this meta-analysis.
You mentioned cost as well, right?
Oh, of course. So, cost, as I mentioned, we're looking at over $10,000 a night for an overnight stay in a hospital. An ER visit is not cheap here as well. I mean, you could potentially be looking at ambulance rides to the hospital. I mean, there are many, many costs to the relapse and rehospitalization, and cost is one of the major things we can look at. So, and cost is important. I mean, we're really dealing at the level of taking care of our patients and helping them stay well, and but cost at the societal level is a major issue, and our systems are grappling with costs and how do we treat with expensive meds, or do we not? We could often go towards, in a P&T committee, or so we could lean towards, well, this is really a costly medication, so let's not use it. But you really have to think about the bigger picture, right? We have to think that, well, let's look at the whole cost. If we could save costs on one end, if we could keep people out of the hospital, keep people out of ERs, and the medication's a little bit more expensive, do we go with that? And the data here shows that there are higher pharmacy costs. The healthcare costs are a little bit lower. It's not hugely different in these studies or in this meta-analysis. But what it's telling us is that there is some cost savings associated with it, despite having a little bit more higher pharmacy costs, and that it's not a more costly, but it does save us some money overall.
Yeah, I mean, we're about to publish a study with a very similar result in which the costs are basically about the same. Mm-hmm. But you're shifting money towards outpatient functionality, let me put it that way, versus inpatient relapse. So if I wanted to spend money, if I have to spend $100, I'd rather spend it on the outpatient side with the person functioning in the community and not on the inpatient side or in the emergency room kind of recovering from a relapse. And I think people tend to see these things in silos, right? Pharmacy budgets separate from hospital budgets, but they really, in totality, our patients are worth the money we spend on them, but we want to spend them in the right places. We want to spend them out in the community. We don't want to spend them in the hospital. And so that's, I think, the point you're making, which is, yeah, these medicines. Look, I would love medicines to be as cheap as possible, and if they could cut the price, I'd be thrilled. But if I had to spend the same amount of money, I want to spend it on the outpatient side. I don't want to spend it on the inpatient side. And then the other thing is
the meta-analysis don't cover all the costs that we look at. This is just looking at administrative claims data where we can measure an ER visit or we can measure a hospital visit. But what we're talking about is, we want to keep them out of the hospital, but there's costs associated with having to drop out of college. There's costs associated with having to stop your work for a couple of weeks. There's costs to the family who have to take a leave from work to be able to stay home and take care. Or, there's so many other costs that we can't even figure in here. So even though it might be more cost neutral, the costs, like you said, to our patients, going into the hospital is much more than just the administrative claims data costs.
So moving away from this meta-analysis, there's some other studies that have looked at, the long-acting injectables. Can you talk a little bit about the effect on recurrent admissions?
Sure. So there's some recent data here, Kim and others. This is a South Korean data set. This is a large study. This is over 75,000 patients. This is over 132,000 admissions. So it's quite large. And LAIs, what this data shows, LAIs does show a lower readmission by about 30% compared to oral antipsychotics and a little over 40% compared to no medication. But this shows us something different. This shows us over time, like you mentioned. So we're looking at sort of this first episode and then the second time and the third time and the fourth time. And you see that continually over time, long-acting even have more and more benefits. So when you look at 4 or more episodes, you can see it really split on the graph between the long-acting, which is the green bar, and then the oral antipsychotics. It's a big difference. And the green bar itself, looking, over time, this is the incident rates over time. It sort of stays the same or goes up a little bit, but you dramatically increase the incident rate in those on oral. So when we're looking at recurrent hospitalizations, this is not just one time that we have patients going into the hospital. A lot of our patients have been hospitalized many, many times. And in fact, this past week, I was in a case conference, and the person that was presented was 44 hospital admissions, and this person was in their 30s. And so I think that we might not even know how many hospitalizations are happening in all of our patients, but sometimes it's a lot, and that's really detrimental. I mean, how do we care for someone who's been in the hospital over 40 times, many times? So again, here, this just shows benefit that, we don't want these continued hospitalizations. And this is even more data to show that over time, we could really cut down on those hospitalization rates if you consider a long-acting injectable in the mix. Do you have any thoughts on any additional thoughts?
Well, let's shift gears a little bit. Just talk a little bit about, what we would consider in terms of picking a long-acting injectable. You want to talk a little bit about that?
Of course. So there's lots of there's more options here than we had before. We have several options, and we'll kind of go into them. But what do we think about? And so we definitely want something. We're looking at efficacy. We look at side effects. We look at many things. And even on this graph here, we're looking like, is this acute treatment? Or how efficacious is the treatment, the other treatment that they've been on, the oral that they've been on? Are we concerned about weight gain and metabolic side effects? Prolactin is an issue with some of them, and then we talked a little bit about costs, but there's many, and we'll go into the next slides, but there's many other variables that can help us decide among agents. But generally speaking, when we're looking at a a chemical entity? Is it going to be a risperidone, paliperidone? Is it going to be an aripiprazole, or is it going to be olanzapine? Those are really sort of our options in the long acting. Like, what are, how do we select that? And we put some sort of guidance together here and sort of thinking through that and what you can consider. But I think those are some of our big considerations. And then we have all these minor considerations that come down, like a route of administration, and we'll talk about that in a few minutes. But I think we have to think about both the efficacy and the side effects.
I think what you're saying is, first of all, the patient has to respond to an oral. And because the oral will guide which choice of LAI you will use. And once that is determined, then you have to decide, are the side effects worth it for that patient? Or because, if you have the choice, you want to avoid a side effect. Sometimes you don't have a choice. Patients only respond to certain things and you're stuck. But if you have a choice between, say, a medication that gives, good effect, but a side effect, and you have another medication that gives a good effect but doesn't have that side effect, you're going to pick the second one, the one that doesn't have the side effect. So the key, though, is understanding the patient's response to the oral. You're always going to have some understanding of that. So in the interest of time, let's talk a little bit about some of these second generations. I will say that especially haloperidol is still used a lot as a long-acting injectable around the country. It's old school, it's efficacious, it has high EPS, but it's not very expensive. And so often it's one of the easier ones to use. And so I wouldn't say that we only use second generations, but our goal is to use second generations because they do tend to have a better side effect profile, especially when we're talking about EPS and tardive dyskinesia. But we would be remiss in not saying that people do still get haloperidol shots all the time. Fluphenazine, not very often, but haloperidol for sure. So let's talk very briefly about some of these second generations. You mentioned you can kind of group them into sort of the paliperidone family, which includes risperidone, the aripiprazole family, and the olanzapine family. So there's sort of three big choices you have to decide on, right?
Absolutely. You mentioned sort of efficacy. If you've been on, these treatments before and you're doing well, I mean, obviously we want to sort of stick with that. So we're thinking of these three sort of treatments. So we understand the side effects of these. We'll come back to that. But we're really now looking at, like, how do we decide, like, which do we pick? And so, if we're on the treatment and we can move to the long acting, that's a great way to move. But we also have, what about the oral overlap? What about the injection sites? What about volume consideration? Do we need to reconstitute? Do we need to keep it in the refrigerator? And this, hopefully, the slides that we've provided, and I know we don't have a lot of time to sort of go into this, but we can just briefly, I think we briefly help by showing that, which medications need to be refrigerated, which ones don't, which ones have reconstitution, which ones don't, how do you do oral, et cetera. So that's where it comes down to when after we know the treatment that we want to go with selecting amongst them, is based on like the intervals and many of these other variables.
Yeah, so I tend to think of this kind of broadly. First of all, in general, longer intervals are better than short intervals, right? So giving an injection every 2 weeks means you get 26 injections. Giving an injection every month, that means you get 12 or 13 injections. Giving an injection every 2 months gives you 6 injections. There's a sweet spot somewhere. I can't tell you exactly what it is. It may be 2 months, it may be a month, in which you get the best connection with the patient and the best delivery of the medication. You and I were talking a little bit about this new drug, this new formulation, the paliperidone 6-month injection. And I want to talk a little bit about that real briefly because it's so new. And the first thought one would have is, wow, that'd be great. I see a patient in the emergency room, I give him an injection, and I don't have to see him for 6 months. Well, it doesn't work that way. Whether you're giving an injection every month, every 3 months, or every 6 months, usually that patient has to graduate from one to the other. So really the person that drug is designed for, paliperidone 6 months, is a graduate of the monthly or the 3-month injection. I would love in the future that we would have the confidence to give someone a medication that would right away that would last 6 months, but that's not what it's indicated for. And we have to be careful not to have people think that. So interval's really important. The other thing that you mentioned is the period of being uncovered. So when risperidone microspheres first came out, it took 3 weeks for the drug to kick in. So you actually got 2 shots before you ever saw any medication from the injection. Now we have medications you can essentially load. Aripiprazole, Loroxo with the Initio. That's a great way to load patients. Paliperidone, you can load patients. So I think that's a real advantage for sure. So I think load, interval, these are important. And of course, always starting with what did they respond to? What did they respond to? Finding an optimal interval, trying to load them if possible. I think these are all the variables you want to include when you think about giving a long-acting injectable. What do you think, Diana, about that? Anything else you wanted to add on that?
Yeah, no, absolutely. I mean, you've hit the hammer on the head. Those are all the pieces. It still doesn't make it an easy, we have a lot of things to pick from. So it's still there's lots of variables that we can also look at. You haven't mentioned if someone doesn't like the needle. There are smaller and larger needle, gauges. We've listed these sort of on here, but really those are the small points. The big points are just being able to decide, what oral do we, which one should we go from oral, and then do we need initial coverage? What can we load with, and then how frequently should we get the injection? And you mentioned the sweet spot of about 2 months. I kind of tend to agree with that. I heard that in another talk I was listening to. We don't know exactly what that is, but there's pros and cons to giving something for 6 months. It sounds great, and if our patients are stable and doing well, that could be just really, really important for us. But then in other patients, waiting 6 months, it's not going to be the best decision. Giving it every 6 months seems on the face value really, really important. Sometimes we're going to want to see patients with an injection every 4 weeks, and sometimes we're going to do every 8 weeks. And that's going to help us drive, which one should we pick? Because the dosing frequency or interval, I think, is one of the big points that you mentioned.
I think we would be remiss if we didn't talk a bit about safety, because these are powerful medications, and one has to think about safety issues. I think that would be really important. Look, we have made huge advances going to second generations, from getting away from EPS, reducing the tardive dyskinesia rate. We've already mentioned that, but we can still have some EPS with some of them, especially at the higher doses. Paliperidone, risperidone have a lot of prolactin elevation, olanzapine, a lot of weight gain, aripiprazole, some akathisia. So look, I would be almost suspicious that the drug wasn't getting into your system if there wasn't at least a little hint of some problem, some side effect with a medication, because that's just the way it's been. We have never had a medication that's completely free of side effects. So we need to think about those when we prescribe it.
Yeah, no, those are really good points. And we do, and I don't want to leave off the idea here that we do have other medications on the market besides these long acting. We do have a lot of newer treatments, and some of them have different side effect profiles than these do. So, in thinking about the whole picture, we are moving into an era where we might have some, we might not see weight gain as much anymore or prolactin as much anymore. And we have those options. But when we're giving a long-acting injectable, we have really 4 sort of options. And you're right, there's side effects with all of our treatments. Everything we do has some risk to it. Not taking a long-acting injectable when it could be a good choice is a risk, or the side effects associated. So every decision we make has a risk associated with it. You know how I feel about sort of prolactin. That's one of the issues that I really deal with, especially in women, and I have published widely on that. But EPS still can remain a problem, and then the metabolic symptoms as well. So we really have to consider what matters to our patients, what they're really at risk for, what they may have had side effects to before. And so these are, we sort of make decisions based on the risk to benefit profile.
Absolutely. I used to say effect trumps side effect. So if you can only find one drug that works, clozapine is a great example. It has a lot of side effects, but if that's the only drug you can use, that's the drug you use. But everything being equal, we try to be careful about not giving prolactin elevation medications to, young women and men even. And so it's really a balancing act between that, figuring out what works the best and then managing the side effects. And the side effects are not uniform. Different patients get them in different ways. So it's really important. So, Deanna, thank you for this great discussion on the important role that LAIs can play in schizophrenia management, as well as our discussion about the available LAIs. Any concluding remarks you want to make?
Yeah, I think I'll just go back to the one point that I made earlier, maybe even a couple of times, is this mentality that they're reserved for chronically ill patients. There's a lot of data to suggest that we should be using LAIs, or at least making sure we're having these conversations and a consideration in the care for our young patients and our early episode patients as well, because they do offer all these benefits, like reduced hospitalization, more adherence, and reduced relapse. So we do have a lot of benefits that we don't have with orals. So I think that mentality and moving it up in care are some of the concluding points that I would like to make. But thanks so much, John.
Good. You're welcome. And just to reiterate our SMART goals from this snack, we wanted to identify the LAIs as a tool to enhance adherence and reduce relapse and rehospitalization in patients with schizophrenia, differentiate the treatment initiation and continuation strategies for LAIs to personalize treatment selection for patients with schizophrenia, and very importantly, incorporate LAIs earlier and more frequently in the acute and long-term management of schizophrenia. So this has been the second episode of our three-part CMEO snack series on overcoming barriers to the use of long-acting injectables in schizophrenia management, because every patient deserves recovery. Please join us for additional episodes in this series as our colleagues address the need for comprehensive management of comorbidities in patients with schizophrenia, as well as racial disparities in patients with schizophrenia. To collect your credit for today's activity, you can click on the link to complete the evaluation. You'll be able to print your certificate from the platform. Deanna, I would again like to thank you for joining me today for such an important discussion. And of course, I'd like to thank you, our audience, for participating and for providing the best care for patients. Thank you.
Thank you.